In this video lecture, we will learn about the drugs that are used to prevent and treat nausea and vomiting, and these drugs are known as antiemetic drugs. So what is vomiting? Vomiting is a forceful expulsion of the gastric contents through the mouth due to mass antiperistalsis. Some of the common causes of vomiting are motion sickness, morning sickness occurring in the first trimester of pregnancy. It can be due to an unwanted side effect due to drugs, toxins, cancer chemotherapy, radiation therapy. Certain diseases are also known to cause vomiting. For example, infection of the GI tract, food allergies, gastritis, gastroesophageal reflux disease, migraine headaches are also known to cause vomiting. Next, we move on to the classification of drugs. To classify the antiemetic drugs based on the site of action and mechanism of action, it is important to understand the pathophysiology of vomiting or emesis. The figure here shows the pathophysiology of vomiting. Vomiting is a complex reflex which is coordinated by the vomiting center that is located in the medulla oblongata. The receptors that are identified in the vomiting center are the opioid receptors, the muscarinic receptor, particularly the M1 receptor, the histamine receptor, that is H1 receptor, the neurokinin receptor, that is NK1 receptor. The vomiting center receives inputs through various pathways, and these pathways have or express various kinds of receptors, and stimulation of these receptors sends signals to the vomiting center which can trigger nausea and vomiting. The major afferent inputs to the vomiting center is routed through the chemoreceptor trigger zone, which is also known as the CTZ. The CTZ is rich in dopamine receptor, that is D2 receptor, and serotonin receptor, that is 5-HT3 receptor. In addition, CTZ also expresses muscarinic receptor, that is M1, histamine receptor H1, and neurokinin receptor, that is neurokinin 1 receptor. So stimulation of these receptors in the chemoreceptor trigger zone sends signals to the vomiting center, which in turn can cause nausea and vomiting. Therefore, drugs such as dopamine antagonists, 5-HT3 antagonists, antimuscarinic agents, anticholinergic agents block these receptors and prevent or treat nausea and vomiting. The second pathway through which the vomiting center receives impulses is through the vestibular apparatus or the vestibular nucleus. Motion during brisk journeys or long journeys is known to stimulate the labyrinthine of the inner ear, and the vestibular apparatus gets stimulated. The vestibular apparatus expresses receptors such as the muscarinic receptor M1 and H1 or histamine receptors, and stimulation of muscarinic receptors and H1 receptors sends signals to the vomiting center which can cause nausea and vomiting. Therefore, drugs such as anticholinergic agents or antihistaminic agents are known to act as antiemetic drugs. The third pathway is through the GI tract. The GI tract expresses 5-HT3 receptors. Any irritation to the GI tract causes release of serotonin from the enterochromaffin-like cells, and serotonin stimulates the 5-HT3 receptors of the GI tract, which in turn sends impulses through the nucleus tractus solitarius, which in turn release impulses to the vomiting center and can trigger nausea and vomiting. Lastly, the cerebral cortex can be activated or stimulated because of emotions, unpleasant sight, smell, and this can also send signals to the vomiting center which can cause nausea and vomiting. Lastly, drugs can act as antiemetic agents through prokinetic effects. So what are the prokinetic effects? Prokinetic agents are also known as gastrokinetic agents. So the lower esophageal sphincter tone is increased and the food moves through the stomach towards the pylorus. There is increased gastric motility, stimulation of peristalsis, and increased gastric emptying. So these are the prokinetic effects produced by antiemetic drugs. So the antiemetic drugs can be grouped into various classes. The first one is the anti-muscarinic agents such as hyoscine or scopolamine, dicyclomine. Secondly, the antihistaminic agents such as promethazine, diphenhydramine, dimenhydrinate, cyclizine, meclizine, cinnarizine. The third group is neuroleptics, which are D2 receptor blockers, and the drugs are chlorpromazine, trifluperazine, prochlorperazine. The next group includes the 5-HT3 antagonists, and these drugs are ondansetron, granisetron, palonosetron, dolasetron, ramosetron. The prokinetic drugs include metoclopramide, domperidone, cisapride, mosapride, etopride, rinzapride, and so on. Then there can be adjuvant antiemetics such as corticosteroids, benzodiazepines, cannabinoids. So this is how we classify the antiemetic drugs, and most of these drugs act on target sites or receptors such as dopamine receptors, 5-HT3 receptors, muscarinic receptors, histaminic receptors, opioid receptors, and so on. So let us now learn more about the prokinetic effects, the mechanisms that are responsible for producing these effects, and the prokinetic agents. So we have already learned that the prokinetic effects are also known as gastrokinetic effects. They increase the gastric peristalsis, increase the gastric emptying, and also increase the lower esophageal sphincter tone to facilitate the gastric peristalsis. To understand the mechanisms that are responsible for producing prokinetic effects, it is important to understand the physiology of gut motility. The figure shown here shows the physiology of gut motility. The GI tract is innervated by the enteric nervous system, which is organized into two types of plexus. The myelinic neuronal plexus is responsible for the motor control, whereas the Misra's plexus is responsible for secretion in the GI tract. The myelinic motor neurons consist of cholinergic neurons, and they release acetylcholine as a neurotransmitter. The acetylcholine that is released into the synaptic cleft binds or stimulates the muscarinic receptor, that is M1 receptor in the gut, which in turn produces prokinetic action such as stimulation of gastric motility. So for a drug to act as a prokinetic agent, it should enhance the release of acetylcholine from the cholinergic neurons of the myelinic neuronal plexus. Now the release of acetylcholine from the myelinic nerve plexus is controlled or regulated by the dopaminergic neurons. Now the dopaminergic neurons, they release dopamine into the synaptic cleft, and the dopamine, which in turn stimulates the D2 receptors that are present in the myelinic neuronal plexus, which in turn inhibits the release of acetylcholine, which in turn inhibits the gastric motility and decreases the prokinetic action. So the dopamine release has an inhibitory control over acetylcholine. Therefore, drugs that antagonize the dopamine receptors and prevent the action of dopamine on the receptors causes increased release of acetylcholine and enhances the prokinetic effects, because the inhibitory control over the release of acetylcholine is lost. Because the inhibitory control is lost, there is more release of acetylcholine, and more release of acetylcholine means more action on the muscarinic receptors, and therefore this enhances the prokinetic actions of the dopamine antagonist drugs. Therefore, drugs such as metoclopramide, domperidone block or antagonize the dopamine receptors, and this increases the prokinetic action. Secondly, the myelinic motor neurons interact with two types of interneurons, that is excitatory interneurons and inhibitory interneurons. The excitatory interneurons stimulate the myelinic neuronal plexus, and this causes increased release of acetylcholine, which in turn stimulates the gastric motility. Whereas the inhibitory interneurons inhibit the release of acetylcholine into the synaptic cleft, thereby decreasing the gut motility. Now the excitatory interneurons expresses the 5-HT4 receptors that are excitatory in nature and that stimulates the release of acetylcholine. Whereas the 5-HT3 receptors that are expressed in the inhibitory interneurons inhibit the release of acetylcholine from the myelinic nerve plexus. Therefore, drugs that stimulate the 5-HT4 receptors such as cisapride, metoclopramide stimulates the release of acetylcholine and increases the prokinetic effect. Whereas, the drugs that antagonize the 5-HT3 receptors depresses the inhibitory neurotransmission in the interneurons and this facilitates the release of acetylcholine into the synaptic cleft and increases the prokinetic effects. Therefore, drugs that act as agonists on the 5-HT4 receptors and drugs that antagonize the 5-HT3 receptors increase the prokinetic effects. So now that we have learnt about the mechanisms that are responsible for the prokinetic actions, let us now know more about the prokinetic agents and how do they act. The prokinetic agents include metoclopramide, domperidone, cisapride, etopride, renzapride and so on. Most of the prokinetic agents act through one or more of the following mechanism. Firstly, by antagonizing the D2 receptors in the periphery, they increase the release of acetylcholine and enhance the prokinetic effects. Secondly, by stimulating the 5-HT4 receptors, acetylcholine releases increase and this increases the gastric motility. Thirdly, by antagonizing 5-HT3 receptors, the acetylcholine release is increased and this enhances the gastric motility. So speaking about metoclopramide, the primary mechanism is mediated through 5-HT4 receptors and stimulation of 5-HT4 receptors increases the gastric motility. Secondly, metoclopramide at higher doses antagonize the 5-HT3 receptors and this in turn increases the gastric motility. Thirdly, metoclopramide also blocks the peripheral D2 receptors and this enhances the release of acetylcholine and the gastric motility. To be kept in mind that metoclopramide can also block the D2 receptors of the CTZ and this accounts for its central anti-emetic action. It is to be noted that metoclopramide can readily cross the blood-brain barrier. It is to be noted that metoclopramide readily crosses the blood-brain barrier and blocks the D2 receptors in the brain and this accounts for its extrapyramidal side effects such as muscle dystonia. Galactorrhea or gynecomastia can also occur with metoclopramide use. Domperidone, on the other hand, is a peripheral D2 receptor blocker. It is a selective D2 receptor antagonist with minimal action on the serotonin receptors or muscarinic receptors. Also, domperidone does not cross the blood-brain barrier and therefore it is devoid of central side effects unlike metoclopramide. So, if we compare the actions of metoclopramide and domperidone, metoclopramide is a highly efficacious antiemetic compared to domperidone because it acts through multiple mechanisms, that is the action on the serotonin receptors, dopamine receptors, whereas domperidone is a selective D2 receptor blocker, so it is less efficacious compared to metoclopramide. Secondly, metoclopramide readily crosses the blood-brain barrier and produces serious extrapyramidal side effects which is absent in case of domperidone because it has poor penetration through the blood-brain barrier and therefore the central side effects or extrapyramidal side effects are not seen and therefore domperidone is a safer alternative to metoclopramide. Lastly, there are prokinetic agents such as cisapride, mosapride, renzapride which act through 5-HT4 receptors and stimulation of 5-HT4 receptors increases the release of acetylcholine and enhances the gastric motility and the prokinetic actions of these drugs. Cisapride is known to cause side effects such as diarrhea, abdominal cramps, abdominal pain. It is also known to cause QT prolongation at higher doses, and this predisposes to ventricular arrhythmias. Cisapride is also an inhibitor of cytochrome P450 enzyme, a major group of enzymes that are present in the liver that is responsible for metabolism of drugs. Therefore, cisapride when administered with drugs that inhibit the cytochrome P450 increases the plasma concentration of cisapride, and this can lead to toxicity. So coming to the uses of the prokinetic agents, the prokinetic agents, since they stimulate the gastric motility, they are used to treat gastroparesis, the post-operative paralytic ileus, impaired gastric emptying, gastroesophageal reflux disease, although the proton pump inhibitors and the H2 blockers are the preferred drugs in gastroesophageal reflux disease. So next, how do we select an appropriate antiemetic agent for the given clinical condition? So the first condition is motion sickness. As we have learned that motion stimulates the vestibular apparatus which expresses the muscarinic receptors and the histaminic receptors. Therefore, anticholinergic agents such as hyoscine or scopolamine can be used, and antihistaminic agents such as promethazine, diphenhydramine, dimenhydrinate can be used in motion sickness. Hyoscine has a short duration of action and is preferred for short, brisk journeys. However, transdermal patches can be used for longer effect. The major drawback of hyoscine is that it can cause sedation because unlike atropine, it can cross the blood-brain barrier and produces marked CNS activity and CNS depression. Therefore, it can cause sedation as a side effect, and driving should be restricted when on scopolamine use. Also, hyoscine is contraindicated in closed-angle glaucoma because it has the property to induce mydriasis and cycloplegia. Because of mydriasis and cycloplegia, they can increase the intraocular pressure, and therefore they are contraindicated in glaucoma. The next condition is morning sickness, and it occurs due to high level of estrogen which stimulates the CTZ or the chemoreceptor trigger zone. It usually subsides in few weeks, but it can also cause hyperemesis gravidarum when it needs treatment. Doxylamine, an antihistaminic agent, is preferred for the treatment of morning sickness as it has been cleared of teratogenic potential. The next condition is post-operative nausea and vomiting, and this occurs in 30 to 40% of the individuals who undergo surgery with general anesthesia. Women undergoing gynecological surgeries experience post-operative nausea and vomiting. To treat post-operative nausea and vomiting, combination therapy is preferred over single antiemetic drug. And amongst the antiemetic drugs, 5-HT3 receptor antagonists have higher reliability index, and therefore 5-HT3 antagonists can be combined with corticosteroids and used to treat post-operative nausea and vomiting. However, promethazine, diphenhydramine, dimenhydrinate, hyoscine, metoclopramide can also be used for the treatment of this condition. Lastly, vomiting due to cancer chemotherapy and radiation therapy can be treated with 5-HT3 receptor antagonists which block the 5-HT3 receptors in the GI tract and treats nausea and vomiting. So with this we come to the end of the topic. We have discussed the receptors that are involved in nausea and vomiting, the drugs, the site of action, the target sites, mechanisms, the uses of these drugs, side effects, and choosing the appropriate antiemetic drug for various clinical conditions.
These are my references. Thanks for watching. Please like, subscribe and share.